and you also see it in the outpatient setting. Pneumonia globally affects about 450 million people a year. That's a huge amount of people. That's about 7% of the population. It turns out that out of those 450 million people who develop pneumonia, there's only about 4 million deaths. So we do treat these things, especially now with antibiotics, and specifically with vaccines, which we'll talk about in a little bit. Today, we're going to talk about the diagnosis, the symptoms, signs, and how we treat pneumonia, and some key things that may come up on tests that you'll be able to use for your advantage. Okay, so the first thing you got to know is what is a pneumonia, and you should know the lungs kind of look like this. You've got the right upper lobe, you've got the right middle lobe, the right lower lobe, and the left side as well, and they branch off too. All of these things keep branching and branching and branching. Finally, what you're going to do is you're going to get to this part where you have these alveolar sacs, okay? They look like little grapes, and that's where the air exchange occurs. So if you were to look at a cross-section of that, here's the alveolar sac, and here is the blood vessel associated with that. What happens is this area gets filled up with infection and mucus and white blood cells, and so what happens is that the air coming in is not able to exchange and put oxygen into the red blood cells. Okay, so you've got an infection there. So what you should see is, number one, you should see a fever, although not always. Number two, you should have an elevated white blood cell count. And then finally, number three, you should see an infiltrate on the x-ray. Well, the fever we get from taking the temperature, a WBC we get from ordering something called complete blood count, and an infiltrate we get by ordering a chest x-ray. But what are the other signs that we'll see? Well, people will have fevers, will have chills. They will feel, if they're young, they're going to have pulmonary symptoms. So that's one thing that you should know is in the young population and in the old population, what do we see? In the young population, you're more likely to see things like shortness of breath, cough, in other words, respiratory symptoms, pain in the chest, okay? Whereas the old might just be confused, sleepy. So in other words, more non-specific symptoms in the elderly population, whereas more respiratory specific in the younger population. Okay, the other thing that you've got to know that's just really important is where these patients are coming from. So there's something called community, and then there's something that's called healthcare acquired. The reason why this is important is because there are different bacteria that are associated with each of these. There's bacteria that's associated with the community, which we'll talk about, and there's bacteria associated with healthcare, for instance, Pseudomonas and MRSA, which require completely different antibiotics. Generally speaking, the thing that's going to divide this is if the patient has come from a healthcare facility into your hospital, then it's going to be a healthcare-acquired infection. If, on the other hand, it's from the community, then they would be coming in from their home or from their apartment complex. If the patient is already admitted to the hospital and they're developing an infection in the lung after 72 hours, then that would be a healthcare acquired. Okay, so let's go through some key points here to kind of weed through this. So we've already decided that an infection in the lung is a pneumonia. Let's look at a little bit more of the history of the patient. Okay, so if you see a patient who's been bedbound, I want you to think of an infection with Klebsiella. That's a Klebsiella pneumonia is a specific type of bacteria. If your patient has COPD, then I want you to think of Haemophilus influenza. That's the classic one. If the patient's been exposed to sheep in the field, then I want you to think about Q fever. And these are associations that I want you to have. If the patient is a bird handler, then I want you to think about psittacosis. Psittacosis is a condition that's associated with birds, chlamydia psittacosis. If you are a hunter, specifically a rabbit hunter from Arkansas, but it could be any kind of hunter. If there's something about bat caves in the question stem, then I want you to think about histoplasmosis. Okay? If the patient is in the Central Valley of California, well, they mentioned something about California. The thing I want you to think about is coccidiomycosis, which is a fungus. And then if they mention something about Chicago or the Mississippi Valley, I want you to think of blastomycosis. Okay, so these are, again, histories that you might get in the patients who are coming in with these symptoms that we've already talked about. Something else that you might see on history is the onset. Okay? If it's abrupt, think about typical pneumonia. That's typically what happens. If it, however, is insidious, I want you to think of atypical. Now, typically is an infection that comes on dramatically, it comes on fast, you have fevers, chills, and you're sick very quickly. Atypical, on the other hand, is not as severe, comes on gradually, and that type of onset is associated with different bacterial organisms, atypical organisms versus typical organisms. Now, the typical organism, as you'll know, is the streptococcal pneumoniae, and that one has actually gone down quite a bit in the last few years, and that's because of what's been going on with the vaccine. So let's talk about that a little bit. So there are two different vaccines in the United States that we're using currently. It's the polyvalent 23, which has been around for some time, and the Prevnar 13. Polyvalent 23 is also known as the PPSV 23, and the Prevnar 13 is also known as PCV 13.
Okay. Anyhow, the gist of that is, out of all those different kinds, don't worry about memorizing, oh, he's a rabbit hunter, you know. I don't care about that. Just keep in the back of your mind that the difference in that hospital acquired or healthcare acquired is important, and community acquired is important. This patient's coming from a hospital environment or a nursing home type environment, they're going to have a different kind of bacteria. Don't worry about memorizing all those different kinds of bacteria. I can just barely say them. No, we don't need to memorize them. Just know that it's a different kind of bacteria, okay? And then the same way, it's at a gradual onset, it's an acute onset, it's a different type of bacteria. They do have a pneumonia vaccine now for everybody that's over 50, okay? They can take that. I haven't got one. No need, all right? But anyhow, just know that the big thing I wanted to sort of get out of there is to show you, hey, there are a lot of different types of pneumonias because they're different bacteria. Different bacteria require different antibiotics. You just can't treat. Now, there's a general antibiotic that a lot of people take, like amoxicillin. They take this. They take it for little infections, but when they grow that, they're going to say, oh, we need this type of infection or this type of antibiotic, like MRSA. They're going to need a different antibiotic for that than they do for cellulitis. Okay, so pneumonia is a big problem. Like I said, a lot of people contract it. just remember the different types of bacteria, the different strains. And that's with every infection. Okay, so we won't get into all that. You'll get into that when you take microbiology later in life, or maybe you might get into it with a little bit college level pathophysiology, perhaps. Okay. Okay, we got two more things to talk about. Then we're going to break it up and do some patient assessment. All right. A spontaneous pneumothorax. A pneumo meaning air, thorax, right? So spontaneous means that this happens spontaneously. Okay. So collapsed lung is the other term for a pneumothorax. Now you have different types of pneumos or pneumothoraxes. Okay. You have a spontaneous pneumothorax, which is very popular with smokers. I've actually had a clinical student diagnose her mom on the way to school with a pneumo. Her mom was a smoker. And all of a sudden she had this sort of an acute onset of shortness of breath, and the mom was saying, I'll go take care of this later, I'll go to the doctor later, and the doctor's going, no, you might want to get this checked out now. And long story short, she did. She dropped her daughter off at school. The shortness of breath got so bad she stopped at a fire station, and then shortly after that she was in the hospital with a chest tube because she had a collapsed lung, or she had a spontaneous pneumo. All right. The way that these spontaneous pneumos take place is that you have a rupture in what's called a bleb, a B-L-E-B, a bleb. Okay, you have an alveolus, right? And an alveolus connected to it. All that toxin that comes in those cigarettes and stuff, they blend that together. They essentially melt those together, okay? And that decreases the diffusion. I think we talked about this a little before. This decreases the diffusion, and then that bleb ruptures. Boom. And causes the pneumo, causes the damage to the lung. What will happen in a pneumothorax, the lung will collapse. Air will escape out of the lung into the pleura space instead of in the lung. Okay, I got a picture. Explain it. Then smokers at a very high risk. Anyways, this person's mom spent a couple days in the hospital re-inflating her lung, and she's fine. If she would have waited, things would have got worse. And then there's sort of the picture. See the dark area? You sort of see over here, this is a lighter black, but here this is dark. That's a pneumo. That's a pneumothorax. And we're just talking about spontaneous pneumothorax. When we get into trauma, we'll talk about tension pneumothoraxes, and that's life-threatening. It's due to trauma. It's damage to that lung tissue due to trauma, like a shooting, a stabbing, a blunt force trauma. Okay, can cause a tension pneumothorax. Tension pneumothorax is a life-threatening event, so that's something that they would have to take care of right away. So you can picture this, or you can see this on an X-ray as well. So what happens is, see the lung is damaged, and air will leak out into this pleura space. Okay, it's not in the air, it's not diffusing, so it will leak out in this space and collapse or shrink down that lung. You had a lung in your hand. Remember the guy talking about squeezing it down, how it will compress? Okay, so a pneumothorax, this is what takes place. They place a chest tube in here to reinflate the lung, to reinflate that space, take that air out, reinflate the lung, and the lung will flow back up and over time heal itself. So, signs and symptoms of a spontaneous pneumothorax, and these go along with the tension pneumothorax just as well. Okay, so you have that sharp pleuritic type pain, like in that pneumonia, right? Here's the biggie: decreased or absent breath sounds or lung sounds on the side of the injury. Okay, So you go and you're doing your good assessment and you listen to those breath sounds. You have this patient that's having increased work of breathing, and you shortness of breath, and you listen, and all of a sudden you have a decrease or absent breath sound. That's a big one. That's why you have to, when you listen to breath sounds, they should be equal, correct? If they're not equal, then that could pose a problem. Shortness of breath, dyspnea with exertion, the Sacs start to drop, late cyanosis, tachycardia because they're going to have an increase in respiratory rate. Part of their lung is not working, okay? So they're relying on another lung, their healthy lung, and it's going to cause increase in respiratory rate, and then that will cause tachycardia. Very late sign, even in a spontaneous pneumothorax, is tracheal deviation. The lung, if it goes unrepaired, this air will continue to escape in this cavity, in this pleural space, right? And it will push the lung over into the mediastinum, and the heart doesn't like that, by the way. The heart wants its own space. It doesn't share space with anybody. And it gets angry. You start having this arrhythmias here, and as it pushes over, will push the trachea over and will cause, in a very late sign, especially in a spontaneous pneumothorax, tracheal deviation. Okay? As it pushes into the mediastinum, it deviates the trachea. That's why when we do our assessment, we feel the thyroid. The thyroid cartilage here. Make sure that's in the midline, right? If this is over here, that would be deviated. So we want to make sure that our trachea is in the midline. So increased respiratory, increased work of breathing, history of smoking, no injury, decreased breath sounds, right? So this patient here, you would oxygenate them, okay? They may require a chest tube to eventually fix this. Definitive care, they may require a chest tube to fix it, oxygen, but here we go. CPAP is contraindicated. Why is CPAP contraindicated? Why do you think CPAP is contraindicated?
Oh, because the pressure will be going into the thorax space.
It's amazing. I'm looking at you and I'm hearing voices. Why do you think CPAP is contraindicated? That's a good point. Oh, you better ask somebody else. Ask Keys. Keys knows. What? Go ahead.
Oh, okay. I'm Keith, by the way. But it's because if you continue to put positive airway pressure, the pressure that's supposed to be going into the lungs goes into the space that is not supposed to be thorax space.
Exactly. You're forcing air with CPAP. You're forcing air into that lung, and it has a hole in it. Okay, and then you're forcing air out, and it's going to increase the size of the pneumothorax very quickly. Okay, so it's contraindicated. You have to remember what CPAP does. CPAP forces air into the airways. We have a hole in there, sorta. Okay, so it's just like forcing water into a container with a hole in it. The more we force water in there, the more it's going to come out, correct? So that's their treatment. Just oxygenate them. They need a hospital environment where they get a chest tube, fix their spontaneous pneumothorax. Okay. So let's look at one. This is a pneumo. It's pretty cool. They did it with some sort of scope. All right. The plastic part, you see a white part that goes in there. That's the needle. What they've done here in this, they didn't place a chest tube they placed a 14 gauge needle into the person's chest, in between the first and second intercostal space, mid-clavicular. See where those directional terms come up? Because of the fact that if they don't know those directional terms, they don't know where to put the needle. So it becomes a bit of a problem because you have an aorta here, correct? You have big pulmonary vessels. You want to make sure that you know where you're putting the needle. Anyhow, I think I have one. So this is not the size. This is a skinny one. It's called a needle decompression. So what they would do, they would take this needle with the plastic part. Okay, this is really for a tension pneumothorax because it's life-threatening. I would do this before they got to the hospital. If I had that patient with a tension pneumothorax, I would do this right away. Okay, I would take this between the first and second intercostal space, mid-clavicular, and stab it in the patient's chest. Careful on that rib. Okay, I would pull this out. This part is now in the thorax, right? Needle's gone. If there's a lot of pressure in that lung because of the buildup in air, right, exactly, it's going to come out here. How do I know air's coming out? Huh? You might be able to hear it, right? If you're silly, you can put it up to your face, like feel it, okay? Or you could put a syringe full of saline, not completely full, but full of saline on this. Don't push it in. Just have the syringe full of saline right here. And what are you going to have? Air coming up here into saline. What are you going to have? Bubbles. It's going to have bubbles. That way I know it's in the right place. Air's leaking out. It's causing bubbles. Okay. It's called a needle decompression. Okay. And this is what they would do on a like a tension pneumothorax. I would not do this on a simple pneumothorax because it's not life-threatening. It can be repaired at the hospital. Sometimes they wait a while to do it. Okay. Just as long as. But if you have that patient that waited like 2 or 3 days with the pneumo, it could be worse. Okay? So there's a pneumothorax. There's also called a hemothorax. What do you think is in the pleural space with the hemothorax? Blood. There's a hemopneumothorax. What do you think's in the pleural space? Blood and air, right? So, good. So this is a pretty cool video that shows.
During normal respiration,
no, it's
the lungs
not.
expand
Not the
and
cool one.
contract within the chest
I'm not
cavity.
sure where.
The lungs are encased by 2 layers of tissue, similar to a fist that has been pushed into a balloon.
Got you all psyched up for the cool video. This is not it.
The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters this space, it is referred to as a pneumothorax. One type of pneumothorax, called a traumatic pneumothorax, can be caused by an injury to the chest. A blunt or penetrating chest injury can cause a small tear on the surface of the lung, allowing air to enter the pleural cavity and to become trapped. The pocket of air produces excessive pressure on the lung, causing it to collapse. A spontaneous pneumothorax occurs without injury as a result of certain lung diseases, such as asthma, emphysema, or COPD. Small air-filled sacs called blebs can form on the lungs. If the blebs rupture, they can release air into the pleural cavity. Pressure from the trapped air causes the lung to collapse. However, a spontaneous pneumothorax can also develop in a person with no obvious risk factors or disease. This condition is more common in smokers and men between the ages of 20 and 40. A tension pneumothorax is a serious complication that can develop with any pneumothorax. If the pocket of trapped air cannot escape and continues to grow, the increased pressure in the pleural cavity can push the heart and major blood vessels to the other side of the chest. When this shift takes place, it causes a significant drop in blood pressure. This is a life-threatening condition that requires immediate medical attention.
Yeah, I got y'all psyched for the cool one. Yeah, I just remembered it's during trauma. We'll talk about that during trauma because it really isn't that needle decompression they would do during a traumatic event. So I got you all psyched up and let you down. You're welcome. So note the signs and symptoms. On all these medical emergencies, we have signs and symptoms, treatment, right? And then vocabulary. You know those three things, you're good to go. Right? Then you just use the process of elimination. Okay. One other thing, and we're like done. Okay. Pulmonary embolism, a PE. Okay. The PE is life-threatening. Okay. It takes place used sometimes from a deep vein thrombus. A difference between a thrombus and an embolism is that the thrombus stays in place and the embolism will move. So an embolism comes from a different part of the body to another part of the body. A pulmonary embolism is that thrombus. You know, when you're on that long airplane ride for 15 hours and they say, hey, you better get up and move. You need to move. You need to circulate your legs. You need to walk around a little bit. They mean that because if you're like me and you take Benadryl and you go boom and you're out for 15 hours, you wake up, you could develop a clot, an embolism in your lower extremities. So an embolism is where that clot breaks off and it travels. This particular one, the pulmonary embolism, will break off and travel and lodge in a pulmonary capillary bed, right? A pulmonary. If it lodged in the head, it would cause a what? Stroke. If it happened some way to get into the heart, it would cause a what? Heart attack. Right. So people who are immobile, trauma takes place, or they have blood clotting factors as well. So we look at this pulmonary embolism, and they are definitely life-threatening. Okay. This clot forms up in this pulmonary vessel. In it, remember we talked about VQ mismatch? It causes a VQ mismatch. This patient with this pulmonary embolism, you can almost tell them right away. They're going to sit upright. The term is bold upright. I mean, they're sitting almost up off whatever they're sitting on, trying to get more air in. You're feeding them tons and tons of oxygen because they're having severe respiratory distress. That patient that we talked about, that they're belly breathing, they're tripoding, they're using accessory muscles, and they just can't get enough air in because of the VQ mismatch. Okay? So that's what that patient looks like. You don't need a degree in medicine to say, I think they're in trouble. They're having trouble. Right? These embolisms can also occur from amniotic embolisms, right? Amniotic fluid post baby. I don't know. There you go. Postpartum, right? You have to use the big word. Postpartum, right? Okay. Post surgery. So they can have a surgical procedure, it breaks off the clot, becomes an embolism, right? Travels. So there's a different ways that they can have these, but all of them are potentially life-threatening. They either have to go in and remove the embolism, which is most common, or try to dissolve it. But most of the time they're going to go in and remove it. They can do this in the cath lab. They can go in and remove that embolism in the cardiac cath lab. They don't prefer it that way, but sometimes they do. They need, the problem with the hospital, if they're a big hospital, then they can go in and try to remove that, and if they can't remove it, then they can take them to thoracic surgery and remove it, okay? The problem going in there in a smaller hospital and trying to remove that embolism or that clot, if they can't get it, then they have to rapidly transfer that patient to somewhere that can do thoracics. So that's a pulmonary embolism. It causes a huge VQ mismatch. Alright. So, chest pain, severe shortness of breath. These guys are going to be really short of breath, huge increased work of breathing, SATs, cyanosis, which is, these things will occur very quickly, okay? Tachycardic, they could be the wheezing, okay? Drop in blood pressure, they become hypotensive sort of as it progresses. One big problem with someone having a pulmonary embolism, and this was my encounter with it, is that the patient can have a heart attack. They can have what's called a global MI. Remember we talked about that ST elevation and those different leads, inferior, posterior, in every lead on the 12 lead. That's what they term as a global MI. They're having the big one, okay? And so a lot of times the PE patient will die from a heart attack or STEMI, a global MI, before the VQ mismatch takes them. They die from a heart attack because of the lack of oxygen and the increased workload in the heart, okay? So there's a couple different cases here. We have seen some PEs come in. You know, the students have seen them. So it again, it's just like a lot of things that you see. Once you see it, you won't forget it. Okay, so you see this patient come in, and later they said, yeah, they have a PE, and you remember what that patient looks like. Okay, so the next patient you see, they're doing that, then the one thing that you think of is right away, even if it's been a long time, is you think of other having a PE, they might have a pulmonary embolism, right? Because you've seen it before. The sight and smells, those create a lot of recall for you. Alrighty? So PE, pulmonary embolism, it is a bad thing. Oxygenate them, even though it's probably not going to do much good. Still oxygenate them. Operate or the cath lab very quickly. Like I said, most of them die from acute MI because of this ventilation perfusion mismatch. Okay, they have this huge mismatch in there. It's quite serious, and a number of things can cause a pulmonary embolism. They're not as common, so we're not going to spend a lot of time on it. I just wanted you to make sure that you knew that, hey, this is what, when they say PE, they don't mean I go out, climb a rope, jump, play soccer. It's pulmonary embolism, like that CR, right? PE, pulmonary embolism, CR, capillary refill. They'll get a lot of attention when they think that they have an embolism, pulmonary embolism. And these embolisms can travel anywhere. They could end up in the leg, right? They clogged a vein in the lower leg. What are you going to do in your assessment? Remember that you're feeling both legs for warmth. You come down here, temperature difference, right? Okay, simple assessment. Why? Then you ask the reason why. Why do you have it? Why is your leg cold? Well, you don't ask the patient that, but you start thinking, why is her leg cold? You know, but then you have to ask questions. Have you been recently bedbound? Have you had recent surgery? Have you come from a long, did you fly in from India? Did you come in from these places? What? Then you play investigator and you start asking these questions. Why? Why is this leg cold? Okay? Because it's not supposed to be, right? It's supposed to be warm, pink, and dry. Now it's cold and decreased pulses. So we figure out why. Why is that? Okay. So quite the emergency on the pulmonary embolism. I just wanted you to have the definition and sort of what it looked like. We're all familiar with pulse oximetry, the different the values in the pulse oximetry. Always try to get a room air SpO2 on the reading. Make sure that the heart rate on the SpO2 correlates with the mechanical pulse. It says never delay, but never say never, right? Even that person, that PE person that's like super, like 50 out of a 10 having trouble breathing, still try to get a room air SpO2 on it. It only takes a few seconds. So, because it gives you the baseline, correct, on how you're going to judge your treatment from then. All right, cool. Finished with respiratory. Week or so we'll go into ultra mental status.